Very good morning to all of you. Before I start my presentation, I purposely remove my all videos. This section is continuing with the videos. Unfortunately, I remove all videos. I want to show what is happening behind the scene, how the stress level of the perfusionist during the minimal invasive cardiac surgery. The talk of my presentation is the role of the perfusionist in cardiac surgery, especially in a minimal invasive, the challenges and strategies we are applying to make the procedure successful and countful. So, I don't have any conflict of interest related to this presentation, and the objective of my presentation is today we're going to talk about the types of the mix. We're going to talk about the role of the clinical perfusionist, especially in high-tech, advanced technology in minimal and invasive cardiac surgery. We're going to talk about the challenges of the perfusionist during the procedure, how he have to maintain the circuit flow and the pressures and to bear the pressures of the team during the cardiac surgery, and how to overcome the challenge and emphasize to the importance of the proactive planning and efficiency of the communications. Unfortunately, there is no laptop in front of us and difficult to go like this and to watch and do the presentation. I'll try my best if it's possible. Nothing is there. No, nothing. Anyhow, we'll try. So, the conventional cardiac surgery, comparing with the minimal invasive cardiac surgery, so the things we take of messages is we reduce the trauma, it's help in a faster recovery, it's shortened the hospital stay length and lower the risk of an infection, and of course last but not least is the customer, like especially people doesn't want a big scar on the chest, and this is like a cosmetically it will be nice and very shorter stay in the hospitals. The history of the minimal invasive cardiac surgery started from 1948, and it ended up in the 1990 with the robotic cardiac surgery. So we started the minimal invasive from 1948. It was in scope, but here the robots are helping, and it's making more easy for the surgeon to do the master special, like the multi-vessel surgeries like a coronary artery bypass, or you can do the mitral valves repair surgeries with the help of the robot. The cases which we are performing here is like we have the mid-cap, we have a coronary artery bypass, multi-vessels, single vessels, mitral valve repairs, and mid-sternotomy, aortic valve replacements, like 8 to 7 centimeter scars given on the sternal, and with a small scar you can approach with the small cannulas, which was decided according to the cardiac out of the patients, and we cannulate it with the small, and with the help of the vacuum assisted we train the volume, and with a small scar of 7 to 8 centimeters, aortic valve was repaired or replaced by the surgeons, and these are the cases we performing here in the Hamad Medical Corporation nowadays. This is my most important slide. See, rather than these all my can someone help me? I need a cursor. Okay. Rather than this one, the cannulation strategy, preparation of the cardiopulmonary bypass circuit, drainage management, myocardial protections, patient management during the cardiopulmonary bypass, and the teamwork. Rather than this one, the most important part is this one. Just look on this. See, perfusionist is not handling the heart of the patients. Perfusionist is handling the surgeon's heart, who's sitting on the dressing, on the surgeon heart, who's on the table, the anesthetist's heart, and of course nurse's heart. So if with the minimal micro mistakes, it will going to tachycardic all our surgeons, all our anesthetists, and they are totally relying on the cardiopulmonary bypass machines. And we are the person, we are the culprit who either we can make you sustain or make you energize and make you in a difficult situation. So the perfusionist is not handling our role is not to stop the heart, not to maintain the circulation of the body of the patients. Our role is to maintain the circulation of the surgeon's heart, to the anesthetist heart, to our nurse's heart, and make a motionless and bloodless field for the surgeon, but not a motionless to the surgeon during the bypass surgeries. I am sure you are agree with all these things. So now, atrial cannulations, like in a conventional, we are opening with the sternal, so we have a big scar there, but in a minimal invasive, or if you talk about the mechanical circulatory supports, so we are using usually the small cannulas with the small techniques, and especially we are using in for the minimal invasive, we are using the femoral artery cannulas like 17 French or 19 French cannulas according to the height and the weight and the body surface of the patient, and how much we need to give the output to the patients. And especially if you talk about the mid sternotomy, so again you need the cannula behind the reinforced. Reinforced cannula is very important. If you are not using the reinforced cannula, might be the cannula get with the kinking, and you are not able to get the flow to the patient at the right time, the right position. So the selection of the cannula is one of the important role to keep the minimal invasive surgery in a proper manners. Of course, we need the venous cannulas, like in femoral cannulas, especially in a minimal mitral valve surgeries. We are approaching to the jugular, and we are approaching to the femoral vein cannulas, and we need to keep the accurate sizes of the cannula during the minimal procedures of the patients. So there is a different size I mentioned before. We have 17 French and 19 French, 21 French cannula for the arterial side. For the venous side, we have the jugular cannula, especially with the minimal invasive, we putting the jugular in 17 French. We don't want to take a big size cannula, because if you're using the big size cannula, and for the femoral, for the lower limb, we are mostly depend on the weight of the height of the patients, like above than the 70 kilograms patients, we are using 25 French multi-stage cannula, and with the help of the multi-stage cannula and with the jugular cannula, we get a good drainage during the minimal invasive, because our target is to provide a bloodless and motionless field during the bypass of the minimal invasive surgeries. So there's two type of circuits available in the markets, and it's up to you according to your centers and your perfusionist in deciding which circuit is ideally for the minimal invasive surgeries. So if you see, this is the first circuit, and this one is your second circuit. In the first circuit, we are using the vacuum assist venous drainage controller, but on the circuit B, you will feel the kinetic assist venous drainage. So this depends, like I work in a Newcastle in a Freeman hospital, where we are using like a kinetic assist venous drainage in the time when we do especially the left heart bypass surgeries, or we do the complex congenital cases. So we use the kinetic force, and with the kinetic force, whether you adding the centrifugal pump in your systems, you suck the blood with the kinetic force. But here now we are using the vacuum assist drainage system controllers, and we suck, in a femoral is a smaller vessel as compared to the central granulations. So there is a chance of compromising the drainage of the volume, and it can be a big disaster during the procedures. So we are using the vacuum controllers assist to suck the blood with the negative pressure, and if you're achieving more negative pressure during the procedure, there is a chance of the blood shear stress will going to increase, and there is a chance of the blood traumatizing, and there is a hemolysis you will find out. But we have to maintain the ideal, although the surgeon will shouting on you, they'll say, oh, no, we don't have the drainage, and you will start they're in a panic situation. But that is the time when you have to be control mode, and you don't go beyond than your limitations, and you have to set your negative pressures what you require. If you just keep helping only to the surgeon, not to the patient, so you're not looking for the patient outcome, then of course you have the higher suctioning, and at the end of the day you will get a hemolysis of the patient. So we are maintaining the suctioning of the vacuum around 40 to 60 millimeter per mercury in a minus. But will not go beyond the minus 60 millimeter mercury, beyond the negative pressures. If you are keeping the pressures minus millimeter 60 above the minus 60 millimeter per mercury, there is a shear rate, there is a shear stress, and you will get hemolysis during the procedure. So we always go with the circuit with the vacuum. And of course, if you are using the if you're using the kinetic force pump, still you have to maintain the negative pressure. So the negative pressure with the kinetic, like in your reservoir, you are keeping like a minus 40 to 60 millimeter mercury negative pressures. But if you use adding the kinetic pump in your the circuit, then make sure in your venous line, the negative pressure will not go more than minus 10 to 15 millimeter per mercury. If you are keeping the negative pressure above than a minus 15 to 20 millimeter mercury in a venous line, your shear rate will be increased, your negative pressure will be increased, and there you will find so many hemolysis. The target of the minimal, and especially in a mechanical assist venous drainage, is to have to keep the negative pressure not beyond than the minus 60 millimeter per mercury. So you will find two type of circuits available, and the circuit A, the implement happening here in Hamad, we are using circuit A, which is having the vacuum controller, and the circuit B is most of the center they are using the circuit A with adding the kinetic force with the pump. So this is the most important the slide of this presentation to maintaining the shear stress, of the blood during the cardiopulmonary bypass. 3 minutes. Sorry, then I have to be fast. So see, this is A, this is B, and myocardial protection is very important, and this is the key role of the minimal invasive cardiac surgery. We have did so many studies related to the myocardial protections, where we have the different brands available in the markets, like we are using the Castoliards, conventional cardioplegia, mini cardioplegia, and Delnido cardioplegia. We come up with the Delnido have the studies showing, there is a studies showing that the outcome of the myocardial protection with the Delnido is much better as compared to the rest of the comparison of the cardioplegia delivers compositions, and with the help of the Delnido cardioplegia. There is a cardiac arrest with the depolarizations, and there is a sequential and lidocaines and magnesium, which is the stability, making the stability of the muscles of the heart during the whole. And we get like about 90 minutes during the procedure. We can stop the heart beyond the 90 minutes, and the effect of the Delnido is much better as compared to the rest of the cardioplegia available in the market. So the managing of return, prevent distension of the heart is the main strategy by the perfusion, and how we're going to maintain the goal direct perfusion is the important during the cardiopulmonary bypass, especially in the minimal invasive surgery, because if you're maintaining the direct goal perfusion during the cardiopulmonary bypass, so it means your perfusion of the body is going adequately. So we are always keeping the DO2 around the delivery of the DO2 during the cardiopulmonary bypass, like 250 to 300 mils per minute, and how are you going to maintaining the hemoglobin hematocrit, and maintaining the oxygen saturation monitors, and maintaining the means pressure of the bypass during the cardiopulmonary bypass. So the strategy of maintaining the good perfusion during the bypass is you are just doing maintaining the GDP of the patient, and cerebral nurse is very important. So our target is to keep being this nurse in a normal ranges, keeping the GDP in a normal ranges, and maintaining the perfusion like you have the indicators like urine outputs. So 1 cc per kg per hour is the ideally urine output during the. This is one of the indicator to maintain the proper perfusion of the body. So these are the challenges. I will not go through with this. I have very less time. So the challenges of the perfusionist is you have to provide the motionless, bloodless, the organ during the cardiopulmonary bypass to the surgeon. So taking care of the heart of the surgeon, taking care of the heart of the anesthetist, taking care of the heart of the nurses. The combination, the team members will provide a good outcome of the patients. To designing the circuit is one of the ideally in a different manners. If you talk about like a minimal invasive mitral or as compared with the minimal multi-vessel minimal invasive coronary bypass, the circuit and the components and the heart lung machine is different as compared with the ordinaries, because the positioning of your machines will be different. The length of the circuit will be increased, the length of your coronary needles and the things will be increased. Then in that time you have put an extraordinary like the homework for the prior to go for the any minimal invasive surgeries. So the strategy, as I already mentioned, the plan is for the cannulation. So you have to discuss with your surgeon which cannulation. You have 1 minute left, so I'll skip this line. Teamwork is very, very important between your team members. These are some strategies which you can take it from my presentation, that according to your the cases, which cannulas, which sides, which size of the tubes you require during the bypass. So I just try to highlight the equipments according to the procedures. So you will not get the same equipment and same custom packs available. The customized way is not going to be work with the different, like a minimal invasive mitral valves. You need to extend the length of your tubes, and as compared to the mid cap, you don't need you will be standby. If you talk about the mid cap multi vessels, then the position of the heart lung machine will be in a different side. So that it depend on the procedure and depend. So I just try to highlight so what the machines you required, which the cell-saver position will be going to be. So you can go through with this presentation. Last but not least, the take-home message is team building is one of the most important part of all procedures. Thank you.
Thank you, Elias, for the presentation. I'm sure that you look after the surgeons, the patient, and your multitask perfusionist. Next is